Hello friends, welcome back to my channel. This video is my rapid revision note of ortho. You can listen it just before NEET PG exam or INICT exam. Starting with median nerve. Median nerve supply first and second lumbricals. Median nerve supplies all thenar muscles except adductor pollicis. Ape thumb deformity, there is atrophy of thenar eminence, thumb will be adducted. When you ask patient to flex first and second digits, patient can't do it. So here the flexor digitorum profundus muscle is not working, which is supplied by median nerve. First three digits won't flex. This is pointing index or Pope hand deformity or Oceaner clasp deformity. Pen test is done to test the opposition and abduction of thumb. Anterior interosseous nerve, which is a branch of median nerve, supply flexor pollicis longus, where flexion of index finger is impaired. This is OK sign or Kilo-Nevin sign, which shows anterior interosseous nerve palsy. So for median nerve, remember ape thumb, pointing index, Oceaner clasp deformity, pen test, OK sign as well as Kilo-Nevin sign. Next about radial nerve. Don't forget wrist drop and finger drop in radial nerve injury. We put cock-up splint for radial nerve palsy. Aeroplane splint is put for axillary nerve injury. There will be injury to brachial plexus, so we put aeroplane splint. For foot drop, we put toe raising splint. It is because of common peroneal nerve palsy. There is impairment of dorsiflexion of foot and eversion of foot, which is reduced. Most common site or clinical feature of foot drop is fracture at the neck of fibula, slap the floor and walk, that is steppage gait or slapping gait is seen in foot drop. Shoulder dislocation, most common is anterior shoulder dislocation. It is the most common joint to dislocate. Neck of humerus fracture, proximal humerus fracture is the most common one and it is classified according to Neer classification. So neck of humerus fracture, there will be axillary nerve injury. Compression of axillary nerve is seen in quadrangular space, so the vascular component gets affected where posterior circumflex humeral artery is compressed in the quadrangular space. Axillary nerve deficit is sensory supply which affects the lateral arm. Musculocutaneous nerve, it affects the sensory supply of the lateral forearm. Reginald Bat's sign is the anesthesia at the lateral arm. So sensory deficit is because of axillary nerve damage. Axillary nerve, there is also motor deficit. Here two muscles are affected, teres minor as well as deltoid. So 0 to 15 degree supraspinatus, 15 to 90 degree deltoid, overhead by serratus anterior. Here teres minor and deltoid are the two muscles which are the motor deficit of the axillary nerve. So deltoid 15 to 90 degree abduction, teres minor external rotator, that is the normal action. So normal action of deltoid is abduction, teres minor action is external rotator. In axillary nerve injury, these both actions do not happen. Abduction as well as external rotation doesn't happen. Holstein's-Lewis fracture is fracture at the spiral groove of humerus where radial nerve courses, that is Holstein-Lewis fracture. Monteggia fracture is posterior interosseous nerve gets affected which course along the radial head which dislocates in Monteggia where there is posterior interosseous nerve which is the motor branch of radial nerve which gets injured. Supracondylar fracture is any nerve is involved, most commonly anterior interosseous nerve, more than median nerve, more than radial nerve, more than ulnar nerve. Code is AMRU. So supracondylar fracture nerve most commonly affected is anterior interosseous nerve more than median nerve, more than radial nerve, more than ulnar nerve. Elbow dislocation, the affected nerve is ulnar nerve. Wrist dislocation, affected nerve is median nerve. Hip dislocation. Hip dislocation, there is posterior hip dislocation as well as anterior hip dislocation. So posterior hip dislocation, sciatic nerve is affected. In anterior hip dislocation, anterior thigh compartment, anterior compartment of the thigh, the nerve affected is femoral nerve. Cubital tunnel near the elbow, it is affected by ulnar nerve. Guyon's canal near the wrist, ulnar nerve is affected. Carpal tunnel syndrome, which is the pronator syndrome. Here the median nerve is coursing between pronator muscles, between the head of the two heads of the pronator muscles. So carpal tunnel pronator syndrome. Here the median nerve is coursing between the two heads of pronator muscles. So carpal tunnel syndrome, think about median nerve. Pronator syndrome also, think about median nerve. Next is supinator syndrome. Supinator syndrome, radial nerve is compressed. Chiralgia paresthetica or Wartenberg syndrome, the sensory branch of radial nerve is compressed. Next is meralgia paresthetica. Here lateral cutaneous nerve of thigh, which is also known as lateral cutaneous femoral nerve, gets affected. Thoracic outlet, it is by C8 to T1 roots. Piriformis syndrome, it is affected by sciatic nerve. Tarsal tunnel, which is by the posterior tibial nerve, which gets compressed. Next about non-union as well as malunion. So in non-union, the cord is flutes, F-L-U-T-S. Non-union, which all fractures we should remember is flutes. F for femur neck fracture, L for lateral condyle of humerus fracture, U for ulna, lower one third of ulna, T for tibia, lower one third of tibia, T there is one more thing, talus fracture, as well as S for scaphoid fracture. So non-union cord is flutes, femur neck fracture, lateral condyle of humerus fracture, ulna lower one third, tibia lower one third, talus fracture, scaphoid fracture. Next is about malunion. Malunion cord is MISC, miscellaneous, MISC. So malunion, the fractures seen are intertrochanteric fractures, MISC, M for malunion, ISC is I for intertrochanteric fracture, S for supracondylar humerus fracture, C for Colles fracture, as well as clavicular fracture. In intertrochanteric fractures, it is extracapsular. It is seen in elderly people. There is more pain in intertrochanteric fractures. Treatment for intertrochanteric fracture is dynamic hip screw. In supracondylar fracture humerus, treatment is closed reduction with K-wire fixation. Next is ORIF, open reduction internal fixation. It is done for fracture of necessity. So ORIF is done in Galeazzi fracture, lateral condyle of humerus fracture which extends into articular surface, neck of femur fracture, olecranon fracture and patella fracture. So as well as in articular injury. So ORIF is done in Galeazzi fracture, lateral condyle of humerus fracture which extends into articular surface, neck of femur fracture, olecranon fracture, patella fracture as well as articular injury. So in olecranon fracture as well as patella fracture, the treatment is tension band wiring. Tension band wiring, what happens is the mechanism of tension band wiring is distractive force is converted to compressive force. Next about gunstock deformity, it is seen in supracondylar humerus fracture. In gunstock deformity, there is cubitus varus. Dinner fork deformity, it is seen in Colles fracture, there is dorsal displacement. Garden spade, it is seen in Smith fracture. It is opposite of Colles fracture. There is anterior displacement or volar displacement. Fish tail is seen in distal humeral fracture. Next is about Galeazzi fracture as well as Monteggia fracture. So for this Galeazzi fracture and Monteggia fracture, remember a cord grimus, G-R-I-M-U-S. G-R-I, that is for Galeazzi and M-U-S is for Monteggia. So in Galeazzi fracture, there is inferior radius fracture which affects the distal radius as well as there is radio-ulnar joint dislocation. Treatment is ORIF. Monteggia fracture, it is the superior ulnar fracture mainly in the proximal ulna and also there is radial head dislocation. Here in Monteggia fracture, the nerve affected is posterior introitious nerve which gets injured. Next, about supracondylar fracture humerus, it is an extra-articular fracture mainly seen in children. 3-point relationship is normal in supracondylar fracture humerus. It happens above the condyle. If 3 points are disrupted, it is elbow dislocation. So what are the 3 points? Medial epicondyle, lateral epicondyle, as well as olecranon. Supracondylar humerus fracture, there is a classification, that is Gartland classification. Most common is extension type of supracondylar humerus fracture. There is dorsal displacement of distal fragment. Malunion is most common with gunstock deformity. Also think about cubitus varus. Nerves injured is AIN, anterior introitious nerve, more than medial nerve, more than radial nerve, more than ulnar nerve. So remember the nerves injured, AMRU, that is the code for supracondylar fracture humerus. That is the order. Anterior introitious nerve more than median nerve, more than radial nerve, more than ulnar nerve. Next, about lateral condyle of humerus fracture, it is intra-articular. Most common is non-union. Here cubitus valgus is seen. Lateral condyle there is L. So cubitus valgus. Here there is delayed or late tardy ulnar nerve palsy. Treatment is ORIF. Distal end of the radius, there is an extra-articular fracture, AP view, that means outside view, not near the joint surface. So distal end of the radius, see the lateral side, dorsally there is dorsal displacement, that is the Colles fracture. Going anteriorly along the thumb, there is volar displacement, that is anterior displacement, that is the Smith fracture. So in Smith fracture, there is garden spade deformity. In Colles fracture, there is dinner fork deformity. Distal end of the radius, think about intra-articular fracture, that is Barton's fracture. Radial styloid fracture, it is Chauffeur's fracture. Next is about the cast. If the cast is put without covering the thumb, that is the hand shaking cast, that is put in Colles fracture. So here there will be ulnar deviation of wrist pronation as well as palmar flexion. Next is about the cast where the thumb is covered. So it is for scaphoid fracture. There is non-union glass holding cast. There is avascular necrosis in the scaphoid fracture, which is a complication. In the proximal waist of the scaphoid, there is retrograde blood supply. Here there is dorsiflexion of wrist with radial deviation. That is the thing we see in scaphoid fracture. Cylindrical cast is put for patellar fracture. X-ray is like skyline X-ray view. Treatment is tension band wiring. Humeral fracture, we put hanging cast or U-slab cast. Foot fractures, when there is a fracture dislocation in the intertarsal region, that is the Chopard fracture dislocation. If there is tarso-metatarsal fracture, that is Lis-France dislocation or Lis-France fracture, or the subtle fracture. Horizontal fracture at the metadiaphyseal junction of fifth metatarsal, that is True-Jones fracture. Avulsion fracture of chip of bone, which is not metadiaphyseal, that is Pseudo-Jones fracture. There is avulsion of peroneus brevis muscle. So this is also known as dancer's fracture. So Pseudo-Jones fracture is also known as dancer's fracture. Next, about hip dislocation. In hip dislocation, there is posterior dislocation of hip as well as anterior dislocation of hip. Posterior dislocation of hip, it is the most common. Anterior dislocation of hip is rare. So first, about posterior dislocation of hip, it is the most common dislocation of hip. There is FADIR, FADIR, flexion, adduction, internal rotation, limb shortening. So when we take X-ray, femur goes up and limb shortens. So there is limb shortening. Most common nerve affected in posterior dislocation of hip is sciatic nerve. FADIR, FADIR, it is seen in posterior dislocation of hip as well as TB hip arthritis. Next, about anterior dislocation of hip. Anterior dislocation of hip is rare. It affects the lesser trochanter which comes into the prominence. Hip dislocates downwards. Here we should remember FABER, FABER, flexion, abduction, external rotation as well as limb lengthening. Most common nerve affected in anterior dislocation of hip is femoral nerve. Faber, Faber, flexion, abduction, external rotation. This is seen in early TB, synovitis, that is in early TB, septic arthritis, iliotibial band contracture, as well as anterior dislocation. In iliotibial band contraction, we should remember Ober's test. Green stick fracture, it is seen in children. It is unicortical fracture affecting radius and ulna. One cortex is broken, that is here this green stick fracture, it is an incomplete fracture. Next, about nightstick fracture or complete fracture, it involves ulna alone. Ulnar fracture, both cortices are involved. So nightstick fracture, it is a complete fracture. So mainly it is a hit with stick or lathi, and also it is seen in elder abuse because of self-defense. So this is about nightstick fracture or complete fracture, which only involves ulna. Next, about torus fracture or buccal fracture, there is no cortical breach, there is no linear fracture. Bending of cortex or buckling of bone is seen in torus fracture or buccal fracture. It is seen in children. Bennett fracture is base of thumb fracture or base of first metacarpal fracture. Fracture dislocation, what happens is two part of the bone is affected in base of thumb fracture or base of first metacarpal fracture, that is the Bennett's fracture. Next is about Rolando fracture or fracture dislocation. Three-part fracture dislocation happens here. The fracture mainly affects the base of the thumb or base of first metacarpal fractures. So in Bennett's fracture, two part of the bone is affected. In Rolando fracture, three part is dislocated. Next is Boxer fracture. Boxer fracture is fifth metacarpal fracture. Bumper fracture is fracture at lateral tibial condyle. It is a type of trauma which can identify vehicle. Second fracture is avulsion fracture of lateral capsular ligament, which is seen on lateral aspect of tibial condyle associated with ACL injury, that is anterior cruciate ligament injury. Investigation for second fracture is MRI. Pylon fracture, it is distal tibial fracture. Aviator fracture is talus neck fracture. Here there is retrograde blood supply which increases the risk of avascular necrosis, and also in aviator fracture, that is the talus neck fracture, we can see non-union. It is a cause of non-union. Port's fracture is bimalleolar fracture. Cotton fracture is trimalleolar fracture. So, in Port's fracture, which is bimalleolar fracture, medial and lateral malleoli are affected. In Cotton's fracture, trimalleolar fracture, medial malleoli, lateral malleoli and posterior malleoli are affected. Jefferson fracture is fracture of atlas. It is four-part fracture. So this Jefferson fracture, it is burst fracture. It is a stable fracture. There is no poor immunological outcome. Hangman's fracture is C2, C3 subluxation of vertebra. There is hyperextension as well as axial loading. Clay-Shawler fracture is C7 spinous process. When it is fractured, that is Clay-Shawler fracture. Emergency splinting is Kramer's splint, which is done in emergencies. We do splinting of limbs as well as fractures. Thomas splint is skin traction, which is known as Buck's traction. Weight is up to 4 kg. So originally this Thomas splint is for TB, but now it is done for fracture shaft of femur. BB splint, that is Bowler Brown splint, that is multi-purpose splint. It is used for splinting as well as skeletal traction. Weight is up to 20 kg. So skeletal traction, there are two pins, Steinman pin as well as Denham pin. So in children, when there is fracture shaft of the femur, two tractions are there, gallows traction as well as Bryan's traction. So in gallows traction, hips are at the air, baby is galloping. So it is put in children less than 2 years or less than 10 kg. For in Bryan's traction also, children less than 2 years or less than 10 kg, we put Bryan's traction. But in the image, in gallows traction, the hips are at the air, baby is galloping. Think like baby is galloping, hips are at the air, gallows traction. But in Bryan's traction, in the image we can see hips are touching in the ground. If the child is big, put hip spica for fracture shaft of femur. Next is about CTEV, congenital talipes equinus varus, which is also known as clubfoot. Deformity is cavus, CAVUS. There is increased arch, cavus, adduction, varus, and equinus. So, adduction is at the subtalar joint affecting talonavicular joint, calcaneocuboidal joint, and varus there is inversion of foot at talocalcaneal joint. Plantar flexion, equinus happens at the plantar flexion of tibiotalar joint. So cavus, adduction, varus and equinus. Adduction at subtalar joint at the talonavicular joint, calcaneocuboidal joint. Varus is the inversion of foot at talocalcaneal joint. Equinus is the plantar flexion of the tibiotalar joint. In severe case of CTEV, treatment is triple arthrodesis, that is talonavicular, calcaneocuboid as well as talocalcaneal joint fuses. Order of correction is CAVE, cavus, adduction, varus or inversion, equinus. So these gets exaggerated plantar flexion. Kite technique should be remembered in CTEV. Ponseti's technique should also be remembered in CTEV. Kite angle is decreased in CTEV. Dennis Brown splint is also put for CTEV. DDH is seen in children of about 0 to 4 years. 4 to 8 years there will be destruction of the femoral head, that is about the Perthes disease. So in a child of 0 to 4 years, if there is a history of hip dislocation, that is DDH. In case of a child with 4 to 8 years, destruction of femoral head, that is about Perthes disease. Next is SCFE, slipped capital femoral epiphysis. It is seen in children 8 to 16 years as well as in adults associated with obesity. Here growth plate is slipped. Posteromedial displacement of epiphysis is seen in slipped capital femoral epiphysis. Diagnosis is by Klein's line, that is the line drawn along femoral neck which should cut at femoral epiphysis. Truthovan sign is also in SCFE. Next about gamekeeper's thumb or skier's thumb, which is also known as Steiner lesion. Here there is an avulsion at ulnar collateral ligament. The muscle affected is adductor pollicis, which gets trapped, and it is the only thenar muscle supplied by ulnar nerve and ulnar collateral ligament. About baseball fracture, which is also known as mallet finger, that is the rupture of the extensor tendon which shows fixed flexion and cannot extend the distal interphalangeal joint. Next about rugby finger or Dorsey finger, it is the flexor tendon rupture. There is extension of fourth finger. Only finger which is extended is the fourth finger. Other distal interphalangeal joints all are flexed. Next is an image showing Sita Namaste. Straight away the patient is showing normal Namaste, that is the prayer sign, which is seen in diabetic cheroarthropathy. Ask the patient to place hands on the tabletop, so hands won't be flat in the table. There is contracture present. Now finger which is persistently flexed, that means there is contracture at A1 pulley which shows entrapment of flexor tendon, that is trigger finger. Next is about swan neck deformity. It is seen in rheumatoid arthritis, flexion of the distal interphalangeal joint and extension of the proximal interphalangeal joint. It is seen in rheumatoid arthritis. One another thing seen in rheumatoid arthritis is buttoner deformity. There is extension of distal interphalangeal joint and flexion of proximal interphalangeal joint. In an elderly patient, there is subcutaneous nodules at distal interphalangeal joint known as Heberden nodules, and in proximal interphalangeal joint, that is Bouchard nodules. Canavel sign, tenderness over and limited to flexor sheath. So in one digit there is tenderness along flexures, and in fingers there is flexion. There is also fusiform swelling like sausage shaped swelling which shows symmetrical increase of digit. There is pain on severe extension of finger more than proximally. Flexed posture of involved digit is also seen. This is suppurative tenosynovitis. Phelon is paronychia, which is infection of the nail bed, which is most common. In phelon, there is infection of pulp of digits. Overall, suppurative tenosynovitis is the common cause which is caused by Staphylococcus aureus. Growth plate injuries, it is seen in children. Here epiphysis is not fused. Classification is by Salter-Harris type classification. Here type 1 is injury going through the growth plate. Example, slipped capital femoral epiphysis. Type 2 is most common one. From growth plate it causes towards the metaphysis, that is Thurston-Hollenstein. It is in type 2 classification of Salter-Harris type classification. Example is supracondylar humerus. For supracondylar humerus fracture, we do closed reduction and K-wire fixation. Remember cubitus varus, gun-stock deformity, malunion, as well as nerve order is AMRU. Anterior introitious nerve more than, median nerve more than, radial nerve more than, ulnar nerve. Type 3 classification is below into the epiphysis. Example is Tilloch's fracture. Type 4 Salter-Harris classification is metaphysis as well as epiphysis is affected. Example is lateral condylohumerus fracture, cubitus valgus, delayed ulnar nerve palsy, tardy ulnar nerve palsy, non-union, fracture of necessity. Here in type 4 Salter-Harris classification, the treatment is ORIF. Type 5 classification, entire growth plate is crushed. Example is crush injury of epiphysis. Trendelenburg gait is seen in greater trochanter of femur fracture, neck of femur fracture, as well as coxa vara congenital. So first about greater trochanter of femur fracture, there is fracture of greater trochanter or muscle inserted to greater trochanter. So muscles inserted to greater trochanter are gluteus medius as well as gluteus minimus, which is supplied by superior gluteal nerve. Now talking about gluteus maximus, it is supplied by inferior gluteal nerve. So Trendelenburg gait is also seen in neck of femur fracture as well as coxa vara congenital. So coxa vara congenital, the neck shaft angle is less than 120 degree. Fairbank triangle is seen in coxa vara congenital. So here how we find the site of injury is there will be drooping of the one hip when patient walks. So how to find the same side as well as opposite side, which side will droop and which side will lurch. So the code here for Trendelenburg gait is DOLI, D-O-L-I. So D-O, droop in the opposite side, L-I, lurch in the ipsilateral side. So droop in the opposite side and lurching in the ipsilateral side, that is the code for Trendelenburg DOLI, that is the code. So if in a case right pelvis droops, left side is the problem. So superior gluteal nerve is affected for gluteus medius as well as gluteus minimus. If bilateral hips are involved, patient will show waddling gait. So here in congenital coxa vara, site of injury is found by watching. When patient walks, we should watch which side of the hip is drooping. So one side will be drooping and the other side will be lurching. Next is about bone tumors. First investigation for bone tumor is X-ray. Investigation of choice is MRI, except in osteoid osteoma where we do CT scan. Now talking about chondroblastoma, which is also known as Codman's tumor, histopathology, we see chicken wire calcification. It is seen in children. This is an epiphyseal tumor. Patient will be less than 20 years. Growth plate is not fused. So epiphyseal tumor, where the tumor reaches the joint surface, end of the bone. That is about the chondroblastoma, which is also known as Codman's tumor. Next is GCT or osteoclastoma. It is also an epiphyseal tumor. Here the patient will be around 30 to 40 years. We should remember soap bubble appearance in GCT or osteoclastoma. Distal end of the radius is the most specific site. Diaphyseal tumors. So diaphyseal tumors include osteoid osteoma, Ewing sarcoma, as well as adamantinoma. So first about osteoid osteoma, here investigation of choice is CT scan. We can see lucent nidus which produces PGE2. There will be nocturnal pain which is relieved on taking NSAIDs. Treatment is CT guided radiofrequency ablation. So tumor at the diaphysis, the second tumor at diaphysis is Ewing sarcoma. Patient will be around 0 to 20 years. Shaft with very large soft tissue which can mimic inflammation with fever, redness as well as swelling. Ewing sarcoma, it is a malignant bone tumor. Next about Osteosarcoma, it is a metaphyseal aggressive tumor. It is a malignant bone tumor. It affects patients with 0 to 20 years. It is a bone forming tumor. Osteosarcoma is a bone forming tumor. It is very sclerotic, lifting of periosteum, which is also known as Codman's triangle. There is perpendicular ossification known as sunburst periosteal reaction. This osteosarcoma, it is a radio-resistant bone tumor. Tumor increases in risk because of radiation. It is radiotherapy induced tumor. So osteosarcoma is a radiotherapy induced tumor. Next, about Ewing sarcoma. Ewing sarcoma, there is periosteal reaction with multiple lamellae, which is known as onion peel periosteal reaction. Histopathology of Ewing sarcoma, there is small round blue cell tumor. There is Homer-Wright pseudorosettes. T1122 should be remembered in Ewing sarcoma. Radiosensitive bone tumor, that is Ewing sarcoma. Diaphyseal tumor at tibia is adamantinoma. So, 3 diaphyseal tumors are Ewing sarcoma, adamantinoma as well as osteoid osteoma. Metaphyseal bone lesion, first is simple bone cyst and the other is aneurysmal bone cyst. So, in simple bone cyst, remember single unicameral cavity, there is presence of pathological fractures. Fragments get floated, which is known as fallen leaf sign or trapdoor sign. So this is seen in simple bone cyst. Next is about the aneurysmal bone cyst. It is also metaphyseal bone lesion which shows soap bubble appearance in metaphysis. Next is enchondroma. Enchondroma, it is multiple. There are 2 syndromes associated with enchondroma. Mainly affects hand as well as short tubular bones. So first is Ollier syndrome. Ollier syndrome is only enchondroma. Maffucci syndrome is tumors which causes bluish skin lesions known as hemangiomas. Next topic is fibrous dysplasia. So when we tell about fibrous dysplasia, remember Shepherd-Crook deformity. So here the tumor is in the neck of the femur with pathological fracture with ground glass tumor. Histopathological evaluation, there is Chinese letter arrangement. Fibrous dysplasia which shows Shepherd-Crook deformity is polyostotic. There is multiple bones associated with McCune-Albright syndrome which shows precocious puberty as well as Cafe-Elot macules. Next is cage FD, that is a cord, cage FD. What is cage FD? In C for chondroblastoma, A for aneurysmal bone cyst, G for GCT, E for enchondroma, FD for fibrous dysplasia. So chondroblastoma, aneurysmal bone cyst, GCT, enchondroma as well as fibrous dysplasia, for all these things extended curettage and grafting is done. Curettage, here we use phenol, and grafting, that is the bone graft. Simple bone cyst, we only do simple curettage. For the above things we told cage FD, for that we do extended curating and grafting. Osteoid osteoma, radiofrequency ablation is done to ablate nidus. In case of osteosarcoma as well as chondrosarcoma, we do surgery. Chondrosarcoma is seen in elderly patients. It is radio-resistant tumor. It is affecting the flat bones, mainly the pelvis. Ewing sarcoma treatment is chemoradiotherapy. Here the tumor Ewing sarcoma is chemo and radiosensitive. Next is about TB spine, that is port spine. Patient will be having fever. There is MRI spine which shows paradiscal involvement. Hip is the most common affected one. Mainly in hip, acetabulum gets affected. There is Babcock's triangle. So Fremister's triad of TB is the TB of the peripheral joints. That is the Fremister's triad of TB is there is erosions present. There is decreased joint space. There is periarticular osteopenia. In stage, there is complete joint destroyed which looks like mortar and pestle appearance. Next is there will be an alternate white and black sclerotic and lytic bands on imaging. That is the Rugger-Jersey spine which is seen in secondary hypoparathyroidism because of CKD as well as renal osteodystrophy. Next is within one vertebra there is blastic periphery lytic center. This is about Paget's disease. So in Paget's disease we should remember picture frame vertebra. It is mainly affecting the elderly patients. There are three defect of osteoblast, that is lytic phase, blastic phase as well as mixed phase. These are the defect of osteoblast. Completely white vertebra is known as ivory vertebra, which is seen in blastic phase. Ivory vertebra differential diagnosis, like it is a blastic ivory vertebra, it belongs to blastic phase. So there is metastasis to prostate, breast as well as carcinoid syndrome, and also Hodgkin's lymphoma is seen. Next is about terrible triad of knee. So terrible triad of knee is O-Donog triad, which affects MCL, ACL as well as medial meniscus. Terrible triad of elbow, it affects elbow dislocation, radial head fracture as well as coronoid fracture. Next is about osteoporosis. Osteoporosis, the bones are bent, weak bones, codfish vertebra or codfish mouth vertebra. There is generalized reduction in bone mineral density. This is about osteoporosis. Investigation of choice is DEXA scan. Next is about LCH. LCH vertebra plana associated with LCH, that is there is complete flattening of the vertebra, that is known as vertebra plana, which is associated with LCH. So it is mainly seen in children. There is multifocal lytic lesion. On electron microscopy there is tennis racket shaped Birbeck granules. Next is salt and pepper skull. It is seen in hypoparathyroidism. There is tiny lytic lesion in the skull. Most common cause is hypoparathyroidism. There is parathyroid adenoma. Investigation of choice is SESTA-MIBI scan. Multiple myeloma, we can see punched out skull, which shows raindrop skull. The large lesion, geographical with beveled double margin, it is seen in LCH. Here there is skin lesions, multifocal bone lesions, vertebra plana, Birbeck granules, everything is seen in LCH. If above is solitary and the same pathology is said, it is eosinophilic granuloma. Next is cotton wool skull, which is showing white spots, that is blastic phase of Paget's disease. There is narrowing of cranial foramina causing optic neuritis. There is also auditory sensorineural hearing loss present in Paget's disease. Next is hair on end appearance as well as crew cut appearance. This is seen in hemolytic anemia because of sickle cell anemia as well as thalassemia. Next is about Sturge-Weber syndrome. There is neurocutaneous syndrome. Only syndrome which is not inherited is Sturge-Weber syndrome. It is a sporadic syndrome. Sturge-Weber syndrome is sporadic. Port vein stain, we can see face with nevus appearance. On X-ray we see tram track skull or calcification. There is history of congenital glaucoma. Refractory seizures are present. Ophthalmic division of trigeminal territory is affected. So this is everything about Sturge-Weber syndrome. Next is chronic osteomyelitis. In the center of the bone there is sclerotic white sequestrum, which is a dead bone, and there is involucrum, that is surrounding sequestrum there is loosened granulation tissue, that is involucrum, which is coming out as discharging sinus, which is known as cloaca. Clinically, if you remove sequestrum, paprika sign is seen. Ring sequestrum is because of external fixator. Along external fixator track there is inflammation. So Ilizaro's ring external fixator is put for lengthening of limbs. Next is about Brody's abscess. It is the abscess, it is the well-defined lesion which is seen in tibia. It is associated with subacute osteomyelitis as well as it is a sclerotic lesion in the tibia. Gutchfield tongs are put for cervical spine traction. Skeletal traction is by Steinman pin or Denham's pin. So Steinman pin, it is 3 to 4 millimeter used for cortical bone. Denham's pin has many grooves. It is for cancellous bone as well as osteoporotic bone. K wire is very thinner. It is 2 millimeter. Distal end of the wrist in a child, if there is widening of joint space, which is the earliest finding, widening of growth plate as well as widening of metaphysis, there is cupping, splaying and fraying of metaphysis. This is seen with rickets because of vitamin D deficiency. Next, about scurvy, it is because of vitamin C deficiency. There is smooth metaphysis, white metaphysis. Epiphysis is very well delineated. There is white line of Frenkel, Wimberger's ring sign. There is no collagen because of absence of hydroxylation of lysine and proline, and there is absence of vitamin C. Next is about IV disc prolapse. Investigation of choice for IV disc prolapse is MRI. Here we do straight leg rising test. There is radicular pain when you raise leg. Sagittal image for IV disc prolapse. The nerve affected or compressed is L5 roots, that is the transversing roots behind the disc in canal. S1 is sacral promontory. L4 and L5 there is herniation, which is the most common site of disc herniation. Exciting nerve root is going out of foramina. There is transversing root, which is most commonly compressed. At L4 there is exciting root, and at L5, which is the transversing root, which is most commonly compressed. Next is scoliosis. Scoliosis, it affects the lateral curvature of the spine. So when we take X-ray, we can see Cobb's angle, which is measured in scoliosis. Adams forward bending test is done in scoliosis. Kite's angle is reduced in CTEV. Ponseti technique is done in CTEV. Decreased Bowler angle, it is in calcaneal fractures. Increased Gisane angle is in calcaneal fractures. Decreased alpha angle and increased beta angle is in DDH on ultrasound. Less than 6 months ultrasound is the first investigation in DDH. Next is about the Milwaukee brace, which is very important. It is very expensive. It is put for 24 hours. Milwaukee brace is most commonly used for scoliosis. Boston brace is expensive. It is also 24 hours wearing. Charleston brace is most effective brace. It is only overnight usage. Next is about hip X-ray. Femoral head is sclerosed with area of lysis, crescent sign of avascular necrosis of hip, and history is telling like patient is on steroids and there was past history of trauma, and also there is association with sickle cell anemia. So everything is correlated to avascular necrosis hip on steroids. So patient on steroids with avascular necrosis hip, that is the diagnosis. Next is X-ray. When we took an X-ray, this is another case of osteochondritis dissecans. So when we take X-ray, there is cartilage defect shown in the medial condyle of the femur, that is osteochondritis dissecans. Next case is osteonecrosis. Osteonecrosis, navicular bone is affected, that is the Colles disease. Lunate is affected and there is avascular necrosis and sclerosis of the lunate bone, that is Kienbock's disease. Calcaneal epiphysitis, there is sclerosis of calcaneal epiphysis, that is Sever's disease. Tibial epiphysis is sclerosed, that is Osgood-Schlatter disease. Tibial epiphysis sclerosed, that is Osgood-Schlatter disease. Bone formation markers are ALP, osteocalcin as well as osteonectin. Bone resorption markers are hydroxyproline, hydroxylysine, deoxyprednisolone, TRAP and telopeptide. Next, about painful arc syndrome. Painful arc syndrome is seen in abduction defect. Mid arc is 60 to 120 degree. Abduction 0 to 15 degree by supraspinatus, 15 to 90 degree which is by deltoid, which is seen in axillary nerve injury, overhead by serratus anterior. Painful arc syndrome is also known as mid arc syndrome. Next is about forgotten tendon of rotator cuff. This is done for subscapularis muscle. Lift of test is for subscapularis. Ask patient to place hand on back. Ask him to lift. This is the lift of test which is done to test the subscapularis muscle. Flexor tendon surgery, that is zone 2. Surgeon should not operate. There is no man's land in flexor tendon surgery. Popeye sign, it is because of the rupture of long head of biceps. Next is about few tests. First of all, modified Schober test. The flexion position we measure with tape. We measure the objective limitation of spinal flexion. This is in ankylosing spondylitis. We see bamboo spine appearance on X-ray. Next is about Adams forward bending test. It is tested in postural scoliosis. So patient in standing position, lateral curvature of spine, it is bent forward. In scoliosis, Adams forward bending test is done. We assess postural scoliosis. So normally when patient bends, it will be straight line. Structural scoliosis is not resolved when patient bend forwards. Next is modified Allen's test. So it is done to test the patency of palmar arch. In case of ABG sample taken from radial artery, testing whether palmar arch is patent. So compress both radial and ulnar artery and the palm becomes pale and open one by one. Open first the radial artery, then open the ulnar artery side. Next is about flexion deformity of spine. We look for iliopsoas muscle contracture when there is hip flexion of one leg. Other leg will be normal and it will be down. Abnormal case, other leg raises in flexion to account for deformity in the other side. Positive Thomas test is done to study flexion limitation because of iliopsoas contracture, because of iliopsoas abscess or port spine. Lateral decubitus of one limb which is flexed, this is Ober's test to check for iliotibial band contracture. DDH, there is two tests, Barlow's test as well as Ortolani test. So acetabulum will be shallow and frequent dislocation of hip is seen in DDH. Barlow's test, adduct the hip which causes hip dislocation, adduct the hip. Ortolani test, abduct the hip and we see hip relocation. Three tests for thoracic outlet obstruction are Roos test, Addison's test as well as Wright test, RAW. Roos test, Addison's test as well as Wright test. So Roos test is also known as EAST, that is elevated arm stress test. Extend and abduct the arm for 5 minutes. Any neurogenic vascular or arterial or venous occlusion symptoms are present, patient can do this for 5 minutes. Addison's test is adduction and extension of arm. Ask the patient to inspire, radial pulse disappears and causes vascular occlusion. One person holds patient arm above head, pulse is felt. This is Wright test. Next is thoracic outlet obstruction. Most common is neurogenic compression, then venous compression, then arterial compression. So neurogenic compression more than venous compression, more than arterial compression. Here the veins and artery compressed are subclavian artery and subclavian vein. Most common nerve roots to get compressed is C8 to T1. Most common cause of thoracic outlet obstruction is cervical rib. Next about carpal tunnel syndrome. Carpal tunnel syndrome, median nerve gets compressed. Reverse namaste sign, that is the Fallon's test. So tapping along the nerve, we do the Tinel's test. Most specific test for carpal tunnel syndrome is Durkin test. Anatomical snuff box tendons. There are two tendons inflamed, that is abductor pollicis longus and extensor pollicis brevis. Finkelstein's test is done here in D. curvine tenosynovitis. Cousin test. Cousin test is pressing on lateral epicondyle of the humerus. This is tennis elbow or lateral epicondylitis. Extensor carpi radialis brevis is affected more than extensor carpi radialis longus. Treatment of Cousin test is counter force brace. Golfer's elbow is medial epicondylitis. Ligaments of the knee are cruciate ligament, collateral ligament as well as menisci. Cruciate ligament consists of anterior cruciate ligament, posterior cruciate ligament. It inhibits both anterior and posterior translation of tibia. On sagittal MRI, anteriorly on tibia, anterior cruciate ligament is present from posterior femur to anterior tibia. From anterior femur to posterior tibia is the posterior cruciate ligament. Most commonly injured cruciate ligament is ACL, that is anterior cruciate ligament. Knee at 20 to 30 degree flexion, that is the Lachman's test. Pull tibia anteriorly. If anterior cruciate ligament is injured, translution is present. 90-degree flexion of knee, we check the anterior drawer test. Meniscal injuries are rotational instability, that is, we do Apley's grinding test. Flexion and rotational testing, the test is McMurray's test. Bending knee and moving laterally, dancing like, that is Tesseli's test. Next is collateral ligament, sideways stability, and that is medial and lateral stability, that is collateral ligament. So valgus stress test is done for medial cruciate ligament, varus stress test is done for lateral cruciate ligament. Pivot shift test is done for the anterolateral corner of knee. Dial test is for posterolateral corner of knee. Investigation of choice for all the knee and ligament injuries are MRI. Gold standard investigation is arthroscopy for all knee and ligament injuries. Ulnar nerve supplies the hypothenar muscles, median nerve supplies the thenar muscles, except adductor pollicis, which is supplied by ulnar nerve, which is the graveyard of ulnar nerve. Palmar interossei, it is unipennate. Dorsal interossei is bipennate. Palmar interossei action is adduction, dorsal interossei action is abduction. Nerve supply for palmar interossei and dorsal interossei is ulnar nerve. Palmar interossei is not present in middle finger. Dorsal interossei is not present in thumb and clitting finger. Lumbricals, there are 4 in number. 1 and 2 is unipennate supplied by median nerve. 3 and 4 are bipennate supplied by ulnar nerve. So median lumbrical is supplied by ulnar nerve and lateral lumbrical is supplied by median nerve. Lumbricals originate from flexor digitorum profundus tendon. Function of lumbrical is flexion of metacarpophalangeal joint and extension of interphalangeal joint. Claw hand is flexion of interphalangeal joint and extension of metacarpophalangeal joint because of median nerve, ulnar nerve palsy, or both happens. Knuckle bender splint is done for claw hand. Treatment is splinting. Splinting is by knuckle bender splint for claw hand. Ulnar claw hand is more than median claw hand. Ulnar nerve is more injured than median nerve. Next is about card test. Card test is done to find the injury in palmar interossei. So the action of palmar interossei is adduction, asking patient to hold the card and adduct fingers. So against resistance, the patient is abducting the fingers. This is the Igawa test. So card test, Igawa test. This is about the palmar interossei. Book test, we test the function holding book, adducting thumbs. When ulnar nerve is injured, patient can't adduct. Patient do flexion of the thumb. This is Frohman sign. Here the muscle is adductor pollicis. All hypothenar muscles are supplied by ulnar nerve. Little finger, that is the digiti minimi, it is abducted. This is the Wartenberg sign. Here the nerve compression in sensory part of radial nerve is affected. So here we told about Wartenberg sign. There is one another thing, Wartenberg syndrome, that is it is seen in white falloc of hair as well as retrochromia iridis.